Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious disease specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of March 16th, 2026. All right, let's get to the questions. Can you speak about immune amnesia caused by measles infection? Excellent question, especially since we're starting to see more and more measles in our communities these days because people aren't vaccinating as much as they should be. Measles is super contagious. It has about a 90% attack rate, and in the pre-vaccine era, pretty much everybody was going to get measles at some point in time in their life. And that's a bad thing because we know that up to 3 people in 1,000 that get the measles will die. 1 in 20 will get pneumonia. Almost 40% of young children will get sick enough to require hospitalization. And there's plenty of other things that can happen, like 1 in 1,000 can get encephalitis, and you can get subacute sclerosing panencephalitis, as well as other things like blindness or other problems. We know that the vaccine is quite safe. A single dose is 93% effective at preventing infection, and the second dose increases that efficacy up to 97%. So unless it's contraindicated, there's really not a good reason not to get the vaccine. But in addition to avoiding the things we talked about, measles infection also adversely affects the immune system, causing something called immune amnesia. We don't exactly know all the ins and outs of how this happens, but there's quite a few studies out there looking at this and what its effects are in animals and humans. For example, measles infection can cause lymphopenia, loss of response to the PPD for tuberculosis detection, diminished response to vaccination, decreased lymphoproliferative responses, altered cytokine response profiles, and impairment of antigen-presenting cell function. Studies in macaques show that the measles virus infects B cells and T cells, including memory T cells, which subsequently get removed by the immune system. In one study in humans, it was noted that the measles infection could decrease the antibody repertoire by 11 to up to 73%. Interestingly, this decrease in antibody repertoire did not happen in children that were vaccinated for measles. This decrease in antibodies and the suppression of the immune system is temporary, but it can last as long as 5 years in young children. Studies have shown that measles vaccines have decreased all-cause mortality by 30 to 90% depending on which country you're in, and those highest reductions occur in countries of lowest means. So that's important. It wasn't just people are being saved from the measles infection right then and there. It was this effect after getting the measles. And in fact, it was noted in one study that 50% of deaths in children occurred within 2 months of having had measles infection. And most of those deaths were related to other infections. And the authors of that study compared that to effects after pertussis, which isn't suspected to cause immune suppression. They noted that in the time period after pertussis, there was not an increase of all-cause mortality and mortality related to other infections. They also looked at the decreases of this mortality of when vaccines were introduced. And there were some countries that introduced measles vaccine widely, like in Denmark, at a time period much later than the United States. And they saw that decrease of all-cause mortality, and especially other infection-related mortality, go down in that time frame that the measles vaccine was introduced. So I think it's pretty clear here that measles vaccine is the key here. We need to prevent infection, and by preventing infection, you can avoid all the things that happen acutely with the infection, but you certainly can help prevent this immune suppression that happens and the risks that come with it. Okay, let's go to the next question. With the ever-growing rise in trends, is there any evidence to back up healthy microbiomes with supplements such as Begin Health to boost babies' overall health and immune system? Another great question, and like a lot of questions, doesn't have a nice, easy, quick response. So the human microbiome is complicated. It has trillions of flora that occur in various parts of our body, and it includes bacteria, viruses, fungi, and archaea. And what we know about the microbiome is really the tip of the iceberg. Probably the best studied portion of the microbiome is the intestinal microbiome, and especially with respect to bacteria. Disruptions of the microbiome or dysbiosis have been associated with susceptibility to infection, autoimmune diseases, and other medical conditions. One attractive possibility to try to prevent or restore dysbiosis is use of probiotics or healthy flora to help replace things that have gone wrong. When we talk about probiotics, we're usually talking about bacteria like lactobacillus or bifidobacterium, but there are other bacteria as well, and there are some yeast like Saccharomyces that can be used. It's important to recognize, though, that there's really a lot of heterogeneity when it comes to probiotics, and they're not closely regulated like medications. And so you may have a single organism, may have combinations of organisms, and there may be differences in the quantity and the amount that's ingested. So it's not surprising as well that there is heterogeneity in the literature. There are many potential benefits of probiotics, and there are studies out there to support that. Animal model and human studies show that probiotics can decrease intestinal flora dysbiosis and inflammation. They can potentially decrease exposure to pathogenic and resistant bacteria. And we know that inflammation can adversely affect the immune system. Probiotics can also strengthen the intestinal barrier through various mechanisms, and they can secrete substances that can inhibit bacteria and viruses. They can also produce or influence the production of cytokines and other modulators that can affect both the innate and the adaptive immune system. When it comes to children and probiotics, there are studies out there to suggest benefit. For example, probiotics may decrease the development of viral and acute gastroenteritis infection after exposure. It may decrease the risk of antibiotic-associated diarrhea. It may decrease the rate of C. diff infection, although that's not something we typically worry about in infants. It may decrease necrotizing enterocolitis, and it may be associated with decreased colic in breastfed babies. But like a lot of things, you can find studies that show benefit, and you can find studies that show no benefit when it comes to probiotics in children and infants. The risk of using probiotics is pretty low, but there can be a risk of infection in severely immune-compromised patients or patients who have central lines, though probiotics have been safely used in those populations as well. So is there anything definitive? No. Is there something to suggest benefit? Yes. You can decide for yourself if it makes sense for the situation that you have at hand. Okay, last question. With the growing concern of antimicrobial resistant bacteria in children, is there data to support rapid antigen tests reducing inappropriate antibiotic prescribing in patients? Another great question. So the CDC estimates that 1.7 million people die every year from antibiotic-resistant bacteria, and they say that about 35,000 of those deaths occur here in the U.S. annually. Judicious use of antibiotics is really important in the fight of developing and spreading bacterial resistance to antibiotics. There are various tests available for rapid diagnosis of different pathogens. In the outpatient setting, rapid antigen tests are attractive because they are quick, they tend to be cheap, and they can be used right there without having to send them off. Antigen tests tend to be less sensitive to molecular tests like PCR-based tests, but PCR-based tests tend to be more expensive and require special equipment. One of the most common antigen-based tests in the outpatient setting are the nasal swab tests used for various respiratory pathogens like influenza, COVID, and RSV. There are many other rapid tests available. They tend to be molecularly based, so they're usually used in emergency rooms and hospitals. But these are tests that can rapidly identify blood culture pathogens, GI organisms, spinal fluid organisms, and the like. When it comes to rapid antigen respiratory pathogen testing and the question about decreased antimicrobial prescribing, you can find studies that support that, and you can find studies that show no benefit. For example, just this month in JAMA Network Open, there was a study published by a group from Italy that used rapid RSV antigen testing in their pediatric clinics, and they showed that if a test was positive for RSV, then they had reduced antibiotic prescriptions compared to those who had a negative test. On the flip side, there was a randomized controlled trial in a pediatric ER in Colorado recently that didn't show a benefit as far as antibiotic prescribing practices go using rapid respiratory panels. They did show, though, that there was more judicious prescription of antiviral therapy, particularly for influenza. There are several other studies looking at influenza and rapid testing that did show a benefit in decreased antibiotic prescription and better antiviral prescription as well. But there are many studies that found no benefit in using these rapid tests to impact antibiotic prescribing practices. Like anything, though, I'm sure there are nuances that may or may not apply to your current situation. I'm a little conflicted when it comes to using these respiratory tests, and we've talked about this in prior episodes. Some of these tests include bacterial pathogens like H. flu or strep pneumo that can be colonizers and are difficult to interpret and may actually induce people to prescribe antibiotics unnecessarily. And in other situations, some of these tests are overused, for example, in young children with bronchiolitis. That's a clinical diagnosis, and it's almost always viral. There's rarely a bacterial superinfection in the lungs, and so it's not needed to know exactly what virus is there. The other problem, too, is that someone could have a bacterial superinfection, so finding a virus doesn't necessarily rule out that infection. So, of course, you have to put all the information together and look at the whole picture and decide, is this just a viral illness? Do I need to know the answer? And is there something else to suggest that there's a bacterial infection that requires antibiotics? When it comes to some of those other tests that we talked about, they can be very beneficial. Having a rapid result for a blood culture can help decrease broad-spectrum antibiotic use and can help narrow down therapy much more quickly. Well, that about does it for this episode of ID Talk. Thank you for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.